I'm here.
Hi, Doyle. We're just waiting on you.
Why, thank you.
You're welcome. So today, we're going to go over trauma codes. For this, you will get trauma triage for an hour. And then on Monday, along with our case reviews, we're also doing trauma skills as our hands-on. And so you'll get another hour of trauma on Monday as well. Okay, so I think this is a perfect topic to start out our summer. If there's any questions, comments, anything, you can either unmute your mic and just ask it or put it in the chat bar, and we'll talk about them whenever you have a question. So we're going to discuss the field triage decision scheme, what most ambulance services use to call trauma codes. Discuss the hospital levels and the transport decisions that we would transport to, and then the QA documentation requirements when we're looking at how we're documenting these trauma codes. So the trauma code activation, this came directly from the North Dakota Department of Health website. It is the law 33-38-01-03. Basically says that all EMS services and trauma centers shall assess patients in activated trauma code based off of this decision scheme. EMS must activate a trauma code if the trauma patient meets one or more of the criteria in step 1, 2, or 3. And we're going to talk about this field triage scheme here in a minute. And this is provided by the current edition of the American College of Surgeons. Step 4 in our scheme is just discretionary criteria. So the provider themselves can either activate a trauma code if they feel that is necessary, but it's not mandatory in that step 4. It is used as a minimal standard, and additional activation criteria may be added based on your service or the hospital. What we're going to talk about today is coming directly out of our protocols. When in doubt, I would say call a trauma code. You're never going to get dinged for calling one, even when it's not, but you will get dinged for not calling one when it was supposed to be called. So this is the field triage scheme. This came directly out of our protocol book. So steps 1, 2, and 3, so I cut this in half for a reason. Steps 1, 2, and 3, these are the criteria that if your patient meets, you will need to call a trauma code and transport to a trauma facility, which we'll talk about in a little bit. So one of the first things is it a trauma patient? If it's yes, you measure their vital signs and level of consciousness. Any GCS less than 14, systolic blood pressure less than 90, and then the respiratory rate less than 10 or greater than 29 is an automatic trauma code. For infants, less than 20 for a respiratory rate. If none of those items are relevant to your patient, you move on to step 2. So any or excuse me, all penetrating injuries to the head, neck, torso, and extremities proximal to the elbow and knee, trauma code. If you have a flailed chest, 2 or more proximal long bone fractures, crushed or degloved or mangled extremity, amputation that is proximal to the wrist and the ankle, so toes and fingers don't count necessarily unless you have other things going on. pelvic fractures or suspected pelvic fractures, any open or depressed skull fracture or paralysis. If you have one or more anatomic of injuries, it's an automatic trauma code. And then if that doesn't suffice or have to do with your patient, you go on to the mechanism of injury. Falls for any adult, it's going to be greater than 20 feet. Children, greater than 10 feet or 2 to 3 times the height of the child. When we talk about vehicle crashes, if you have any intrusion greater than 12 inches, and on the occupant side, greater than 18 inches on any site of the vehicle, ejection, whether it's partial or complete, is an automatic trauma code. Any death in the same passenger compartment. So I just watched something not too long ago where we talked about this, death in the same passenger compartment. And I'll just throw out a scenario and you guys can tell me what you think. So if you have two vehicles, a semi versus a car, and the semi driver's fine with no injuries walking around scene, and then in the car you have a driver who is dead on arrival, and then another passenger who is hurt. If you transport that semi driver, is he an automatic trauma code based on criteria in step 3? What would you guys think? Or how would you guys deal with that? Kasha says no. Zach says no. Okay, everyone's typing. Mandy, no. Lisa, no. Yeah, okay. So this was a huge discussion. We all said no, even in this class that I took. Like Kasha just said, the semi had a whole different mechanism compared to the car. So he does not automatic constitute as a trauma code based off this criteria. Now, if he had other things going on, maybe. Would the passenger in that car who is alive and injured constitute as a trauma code? Yes, because that is in the same passenger compartment of that vehicle. Good, good, good. Any automobile versus pedestrian or bicyclist, anyone that's been run over or has a significant greater than 20 mile per hour impact, any motorcycle crash greater than 20 miles per hour. So this is all steps 1, 2, and 3. If you have any of these steps or any of these findings in your patient during your initial assessment, trauma code needs to be called to that receiving facility. Now, step 4, if you don't have anything in steps 1, 2, and 3, then we're going to move on to step 4, and this is going to be based off of provider impression. Age is a big factor. Those older adults that are on some medications that could potentially, those beta blockers that could potentially not raise their heart rate. So any older adult greater than the age of 55 would have a higher index of suspicion. And then children should be triaged and be sent to pediatric capable trauma centers if at all possible. Any patients that are on anticoagulation or have bleeding disorders, burns, time-sensitive extremity injury, anybody that has end-stage renal disease requiring dialysis, pregnancy greater than 20 weeks, and then EMS provider judgment. If you have 0 things, but in your gut telling you that something could potentially be very wrong, EMS provider judgment is going to save you. You're never going to be wrong for calling a trauma code if you don't have, your patient doesn't meet this particular criteria. So when in doubt, transport to a trauma center, call the trauma code. the good thing about this is when we transport over to Mobridge, those guys can downgrade it if they need to or want to. But at least on our end, we're doing our job and we're following our gut. Anybody have any questions on our guidelines? So transport. I found this interesting. And also on the Department of Health website. So our transport plans, every EMS system has to have a transport plan in place, covering what area you cover, and if an accident happens in any of your area, what hospital are you transporting to? We can bypass the nearest designated trauma center for a higher level trauma center, as long as it doesn't result in an additional 30 minutes or more transport time. That's really not possible here. I know down in South Dakota, a lot of us transport over to Mobridge. There has been times where we transported patients directly up to Bismarck from South Dakota, but mostly North Dakota is all transporting their trauma patients up to Bismarck, which is the right thing to do. We can transport to a higher level trauma center with permission from medical direction. I believe that it's just written in our protocols that we can bypass IHS, considering they don't have CT capabilities. So here is the North Dakota Trauma System map as of 2020. Mobridge is on this because they are North Dakota certified as well as a trauma center, because they have a relationship with the Bismarck hospitals for whatever trauma that comes in there that needs to be transferred. They go to Bismarck. So Mobridge is on this map because of that. So Fort Yates and Mobridge are both level 4 trauma centers. And we're going to explain why this is like this here in a minute. And then we have Sanford and St. Alexis, which are both the level 2s, which generally would be transferring to or transporting to in North Dakota. So our level 2 trauma centers, in order to become a level 2 trauma center, you have to have 24-hour immediate coverage by general surgeons, as well as specialists like orthopedics, neurosurgery, anesthesiology, emergency medicine, radiology, and critical care. And then they have to have a good working relationship with a level 1 trauma center if it's available, which North Dakota does now have, in case they need microvascular surgery. Level 2 trauma centers are going to provide trauma prevention and continuing education to their staff and incorporate a comprehensive quality assessment program. Level 2 trauma centers work side by side in getting the level 4 and level 5s resources that they may need. Your level 4 trauma centers, so I'm only going to talk about level 2 and level 4 because that's the ones that we deal with. Our level 4s do provide basic emergency department facilities to implement ATLS protocols and 24-hour lab coverage, as well as radiology. They have to have trauma nurses available, as well as physicians available upon patient arrival. So these guys, the reason why Mobridge can be a level 4 is they have a ATLS physician, a doctor, who is on call 24/7. So when you call that trauma code, they have 20 minutes to respond to the hospital and get there from the time that they are called from the hospital staff. So the mid-levels should not or will not be assessing your patient as long as it's not a mass casualty and everyone's overwhelmed. So if it's a regular trauma code, a physician gets called in, an ATLS physician, to take care of that patient. Level 4s may provide surgery and critical care services if available. Mobridge does have a general surgeon. Okay, and CRNA and surgery staff if needed. You do not need to have a CAT scan to become a level 4 trauma center, but you do need to have a transfer agreement with a level 1 or a level 2 trauma center in case your patient needs a higher level of care. Level 4s incorporate a comprehensive quality assessment program, as well as prevention efforts and outreach programs to its communities as well. So we got Sanford and CHI, both level 2 centers. IHS, the level 4 with no CT capabilities. Mobridge, level 4. Really, the only difference is they have surgery capabilities as well as CT capabilities. In order to keep your level the same, they do require North Dakota and South Dakota both require site visits every 3 years. So every 3 years, the team goes to that hospital, make sure everything is what they recommend for a level 4 facility, and then it's renewed every 3 years after that. Okay, so the QA documentation. This is when our reports are pulled at the state level and internally for us, these are the things that I'm going to be looking for when it comes to QA documentation. It just makes it easier to find things. So we're going to talk about your scene time is going to be QA'd, the time that trauma code was called, the earlier the better, an initial GCS, arrival GCS, warming measures, and then fluid administration. So let's dig deep into those. So scene time, we all know less than 10 minutes. If for some reason you can't make it off the scene in 10 minutes, you need to document a reason why you had a delay, whether it was extrication from the vehicle, whatever the case may be. If it's greater than that 10-minute mark, there has to be a reason for delay. Otherwise, I don't know the delay, so it gets dinged. And that could be in your narrative. The time trauma code was called. The time is important. The sooner we call these trauma codes to these facilities, the more time that those facilities have to get their teams together to benefit your patient by the time you get there. This actually can be documented in 2 different areas on your PCR. I don't care which area it gets documented in, as long as it's documented in at least one. But on the scene tab on the mobile touch system, there is if you click treated and transported, there is this pre-arrival alert and activation that shows up. And there's a lot of different activations in there. Trauma, stroke, STEMI, whatever the case may be. In this case, trauma. And then whatever time that you called that facility to say, hey, I'm bringing in this trauma code. I'll give you a report later. That's the time that I need. Or you can just place it in your narrative. But I need the time that trauma code was called. GCS, after looking through some reports last month, we don't do that great of a job of documenting our GCSs. There's a couple ways you can do this too, but with trauma, they're going to be looking for the initial GCS on scene of your patient, fifth and the numerical number. So this can either be done in your narrative or in the events tab, where you can just plug in a GCS along with your vitals. And then generally, you should have another GCS documented when you reach that destination of wherever you're going. Did that GCS stay the same? Was it lower? Or did it get better? We don't know that if it's not documented. So you can use the same format as above, place it in your narrative, or put it in the events tab where you can fill out your GCS along with your vitals. So warming measures. So I bought a PHTLS book last night to get some more information on this because I like statistics. So 50% of trauma patients transported by EMS are unintentionally hypothermic by the time they reach the hospital. Oh, don't mind the last sentence. I was wondering where that sentence went, and there it went. So our job is to keep them warm, obviously. We know cold trauma patients is part of a lethal triad of mortality. So it doesn't have to be cold to create a hypothermic environment. In trauma, hypothermia begins when the core temperature dips below 96.8. So anything between 36 and 34 degrees Celsius is considered mild hypothermia. 34 to 32, moderate, and less than 32 is considered severe. So if your patient has the potential for hypothermia, especially if it's a multi-system trauma patient, we need to be documenting the type of warming measures that we use on our patients, whether it's warmed IV fluids, which we carry. But if someone from the state is reading our report and we don't specify that we've hung warmed IV fluids, they're going to assume that they were cold. So we have to put that, document whether your rig heat was turned up, whether you were using hot packs, covering your patient with blankets, whatever warming measures you're using, those need to be documented as well. And then fluid administration. Who remembers, or who still does, every trauma patient gets a large bore IV and a fluid bolus.
A large bore IV.
They all get a large bore IV. So we're not pumping these patients full of fluid anymore. And per our protocols, we use LR trauma patients, which is good. IV access and fluid administration should not delay your transport. These should be done on the road, on your way to your receiving facility, especially since we're so rural and it takes us at least 30 minutes to get to a hospital unless you're transporting to IHS. So this stuff should be done on the road when you're off scene. Your IV fluids, if you're going to start them, if your patient is normotensive, we don't need to be pumping them full of fluids. We can start fluids and put them at a TKO rate. If you have to bolus some fluid because your patient is hypotensive, you should titrate that to maintain a pressure between 80 and 90 millimeters of mercury. We don't want to bust up any clots that our patients are trying to help them stop their bleeding. We also don't want to make them colder or dilute their blood factors. If you like using MAP, you should keep your MAP between 60 and 65. The only considerations to this would be your spinal shock and your neuro shock, where we're going to keep our MAP a little bit higher than 65, be 65 to 70, 75. Other than that, our fluid administration should be pretty limited on our patients. So that's another QA factor that we'll be looking at is were fluids started in the trauma patients? What was the volume infused? That was the other thing, is the total volume infused has got to be documented, which we all do a pretty good job on. And was it necessary based off of their pressures? Does anyone have any questions? No, do you?
Yeah, my guy that hit the high five the fire mirror yesterday,
Mm-hmm.
that wasn't a trauma code because it was distal to the elbow,
Wrist.
right?
Right. Okay. Well, if there are no other questions, that is all I have for you. Monday we'll talk about, there was a few traumas last month, so we'll go over the QA on those. As well as some case studies. And then some trauma skills. If there are any trauma skills that you want to go over, send me a text and we will go over those trauma skills. The biggest one that I know of that people wanted to go over was the traction splint. So we'll be going over that for sure. Splint. Thanks, Zach.